Welcome to the Aging and Long-Term Care Committee. It is Wednesday, March 9th, 8:30 here in the Capitol. Thank you for joining us. Can't hear me? I'm on this microphone. Oh, okay. We'll start that over. Welcome to the Aging and Long-Term Care Committee. It's Wednesday, March 9th, 8:30 here at the Capitol. Thank you so much for joining us. We have quite a few presentations today that I'm looking forward to. Some are in person, some are here online. We'll just get going. We are going to start with Nicole Stockart with the DHS, Department of Human Services. Nicole, I think you're online. There you are. Go ahead with your presentation. Thank you.
Hi, Nicole. This is Mary McGurran. Would you like me to start?
Go ahead, Mary. Thank you.
Okay. Good morning, Senator Housley and Madam Chair. I'm Mary McGurran from the Minnesota Department of Human Services, and I'm the supervisor of the Adult Protection Unit at the department. And we're going to talk a little bit this morning about some information about the Minnesota Adult Abuse Reporting Center and our county administered adult protection system. We can go to the first slide. So as you'll be hearing from our colleagues at the Department of Health today, they are one of the 3 lead investigative agencies responsible for allegations of suspected maltreatment of a vulnerable adult when they relate to a provider licensed under their agency. And I'd like to take a few minutes this morning to just step back and provide the members of the committee with a higher view of the Vulnerable Adult Statute and what it does. The Older Adults Administration within the Department of Human Services provides support for counties who are responsible for the adult protection reports and investigation of people living in their home or in the community when a licensed provider is not alleged responsible for maltreatment. At the highest level of the Vulnerable Adult Act, we establish state policy for the protection of adults who are especially vulnerable to abuse, neglect, or financial exploitation because they receive services licensed by the Department of Human Services or the Department of Health, or because they're living in the community and have a specific circumstance that makes them more vulnerable to maltreatment. The statute also establishes the agencies that are responsible for responding to allegations of maltreatment. The Health Department, when the allegation relates to a person who is receiving services from a provider that is under their regulation. The Department of Human Services, when the allegation involves a person that is receiving services from the Department of Human Services, and counties, Adult Protective Services, when the individual isn't receiving licensed services and the provider member is a family member or a friend or a personal care assistant. And we can go to the next slide. The Vulnerable Adult Act, the policy in the statute, also identifies what is maltreatment. What exactly do we mean? There's, I'm sorry, I want to make sure we're looking at the same slide. So there's 3 types of maltreatment under the statute: abuse, which includes physical abuse, sexual abuse, and emotional abuse; neglect, when the vulnerable adult isn't receiving the food, shelter, healthcare, supervision, or services necessary to maintain their health or safety; and financial exploitation, when someone is stealing from them, frauding their finances, diverting their medications, or using deception or fraud. And the next slide. So the department also operates the Minnesota Adult Abuse Reporting Center. In 2015, the legislature moved us from a county-based reporting system with 168 different places to report suspected maltreatment of a vulnerable adult to a single centralized reporting center, the Minnesota Adult Abuse Reporting Center, or MARC as we call it. MARC provides 24/7, 365 reporting for mandated reporters and the public, with a single toll-free number for the public and a web reporting system for mandated reporters. MARC does not screen the reports that are received because the reports are referred to the agencies responsible, one of the 3 lead investigative agencies. MARC doesn't do any intake on the reports. We accept the reports, make the required notifications and referrals, and we also do not do the investigations or make any determinations at MARC. And MARC is not a substitute for 911. Every caller or reporter to MARC is referred to 911 if necessary due to the circumstances of the incident. Next slide. This slide is a visual representation. Whoops, I'm sorry. Yeah, this slide is a visual representation of the MARC process. So you can see at the top, the reports are coming in from the nursing home incident reporting system that's operated by the health department that feeds into MARC. And we have online and phone reporting for MARC. So all those reports then go down for required referral or notification. And starting at the left, you'll see every report goes to one of the lead investigative agencies, a county, the health department, or a DHS under the Office of the Inspector General. Every report is assessed for immediate risk to the person, to the vulnerable adult. And if there's an immediate risk assessed, that report goes immediately to Emergency Adult Protective Services operated by counties, regardless of who the lead investigative agency is. And then if a crime is suspected, the report is also referred to law enforcement immediately. And about half of the reports that we receive go to law enforcement, as well as to the civil lead investigative agency. And when death is reported as suspected related to maltreatment, the report also goes to the medical examiner and the Ombudsman for mental health and developmental disabilities. Go to the next slide. So the impacts to the reporting system you can see from the pandemic, the reports decreased about 13% between 2019 and 2020. And reports are now in 2021 started to return to a more historical pattern. We had an 11% increase between 2020 and 2021. This data is all up on our dashboard, the Department of Human Services Vulnerable Adult Dashboard. And we can provide a link to that if that would be helpful as well when I'm done. And next slide. So as mentioned here, the investigative responsibilities or the response to the reports are divided between the three agencies, the Health Department, DHS, OIG, and Minnesota counties. So you can see here the changes between 2019 and 2020 and 2021 in the reporting that went through this kind of breaks down the previous 13% decrease between 2019 and 2020 that I described by agency responsible for the report. And you can see there were some definite changes in those years. Next slide. This is a slide that shows the age of the people who are reported to the Minnesota Adult Abuse Reporting Center as vulnerable and expected of experiencing maltreatment. You can see that slightly half of the vulnerable adults that are reported to MARC and referred for response to maltreatment are considered older adults. And that might be surprising, but as MARC is the statewide reporting center for suspected maltreatment of all vulnerable adults, the numbers reflect what we see in our state. Next slide. This is a breakdown of the allegation types reported to MARC, and we have each allegation is shown here. And this is data for all lead investigative agencies combined. You can see that caregiver neglect and self-neglect, neglect combined, is the most common reason that vulnerable adults are reported to the Minnesota Adult Abuse Reporting Center. Someone's concerned they're not meeting their necessary needs for food, shelter, healthcare supervision needed in order to maintain their life, health, safety, or comfort. Financial exploitation. If you look at fiduciary and non-fiduciary sources of financial exploitation, that would be the next most common. Next slide. So now that we've talked about all of the reports that are coming into the state and the ages of the vulnerable adults who are impacted, as well as the types of maltreatment that we're seeing, I'm going to talk a little bit about our county adult protective services system. Minnesota is fairly unique in that our adult protection system is county-based. In Minnesota, that means that there are 87 counties or county collaboratives that work under the statute to protect vulnerable adults, both older adults and people with disabilities living in their own homes. On top of that, counties have very unique responsibility when the health department and the DHS OIG are responsible to investigate. the allegation and determine who's responsible, counties are also responsible for service interventions with the vulnerable adult to assess their safety and their strengths and their needs, to develop a safety plan through engagement with that person and their supports, and then offer services and solutions to stop the maltreatment and reduce risk and prevent reoccurrence. So these two roles that the counties have of investigation and services can be in conflict. For example, if a family member is alleged responsible for neglect of a family member, adult protection is investigating the family and making a determination and sending them a letter about whether or not the county has decided that they've neglected that person. And they're also responsible to engage that family member, who's often a loved one, and providing necessary services to that person. They also have to engage them in services to stop the maltreatment and to prevent it from reoccurring. So these two roles that counties play can lead to conflict and really difficulty in engaging the vulnerable adult and their support person or their family member in the services. So in adult protection, we want to stop the maltreatment and prevent maltreatment from happening again. Next slide. This slide shows the 3 lead investigative agencies again and the differentiation of the roles. So you'll see in white at the top are the Health Department and the Department of Human Services, and they're responsible for investigations on the left. And then on the right, the services, green, are adult protective services, where we have both the services and the investigation, as well as emergency protective services, regardless of if the Health Department or the Department of Human Services are responsible for investigation. The counties are always responsible for services and support for the vulnerable adult. They're person-focused services. The next slide. As you saw from the previous numbers, most vulnerable adults reported to MARC are referred to a county as a lead investigative agency to offer services and supports for the person. And we've talked nationally about how most adult protective services are administered by states. And in Minnesota, we have a county administered state supervised system. So counties and states work in partnership to protect vulnerable adults in Minnesota. DHS's roles in the adult protection system are to encourage reporting by the public and by mandated reporters, and operate the Minnesota Adult Abuse Reporting Center in a way set up through the legislature to make sure that that reporting is consistent and is available for the public and mandated reporters. We also offer a technology system for the reporting system, as well as for our county partners, the Social Service Information System, or SSIS. We work to promote statewide consistency in adult protection response across all of our counties. It's very important when you have a county administered system that people can expect the same response no matter where they are located in the state. And we also promote person-centered outcomes for vulnerable adults who are referred to adult protective services because there's a suspicion that they're being abused, neglected, or exploited. And we do this through policy tools, policy support, through training, through offering structured decision tools for adult protection, for screening, safety assessment, and service planning. And we also serve as a resource for our counties for compliance with the statute and policy, and for consultation in individual situations that are challenging. We do quality assurance through the Human Service Performance Management System, which is another policy. And we also coordinate the maltreatment review panel for vulnerable adults, or the person that has authority to request a review of the investigation determination on their behalf. And then the department, through the Office of Inspector General, is also a lead investigative agency. Next slide. So historically speaking, the vulnerable adult statute and adult protective services in the 1980s were established without funding for adult protective services. So adult protection relies heavily on local county funding to operate their programs that provide this critical protection for vulnerable adults who are living in their own homes in the communities. For tribal nations, there's no dedicated state funding or federal funding for adult protective services. In 2012 and 2019, thank you, the legislature added some state funding for county adult protective services, and but about half of the funding is still local government. The first ever federal funding that's dedicated to adult protection came last year through the Coronavirus Relief and Response Act. That was the first time that we ever had federal funding dedicated to adult protective services. Next slide. So I want to just provide you a really brief update on our next steps to improve the adult protection system. As many of you know, DHS is involved in a stakeholder-led process to redesign and update and modernize the Vulnerable Adult Act for adult protective services. We've engaged more than 260 stakeholders. This process has been very driven by stakeholders. It arose out of what we were hearing from county partners as well as from advocates and family members regarding their concerns about the Vulnerable Adult Act. And what we found through multiple stakeholder engagement opportunities is that our adult protection system does lack statewide consistency. Vulnerable adults receive a different response depending on where they live in our state. We also heard from stakeholders that we need a shift, that the shift on investigation and blame for the person alleged responsible in our adult protective services is not leading to good outcomes for vulnerable adults. We want to support the vulnerable adult and their chosen supports, which are often their family members, to have outcomes that result in safety and dignity and prevention of maltreatment for that person, but that also maintain those relationships and those informal supports. We also found that we needed, from our stakeholders, increased data sharing in order to inform the decisions and the assessments and the process for county adult protection. So we want to protect privacy while allowing coordination of information to increase the safety of the vulnerable person. And would be remiss if we didn't mention that there's a lack of stable funding that contributes to the differences in service response across our Minnesota counties. We're working with our partners to develop a more person-centered adult protection system by redesigning the services provided by counties under the Vulnerable Adult Act. And next slide. Thank you very much for this opportunity to talk about our reporting center and our county-based adult protective services. Thank you.
Thank you so much, Mary. Members, are there any questions? Senator Curran.
Thank you, Madam Chair. Ms. McGurn, I didn't hear anything about how we've improved care. And over the last 2 or 3 years, we know that there's been tremendous strain on all resources, and our elder care network is collapsing. And what I didn't hear anything in your conversation or the presentation that talked about how we've improved it. It highlighted at a really high level, but we really need to understand what's the state of the union or the state of the health of our elder care network, the actual network that provides the care and service. And so I'd be curious, in your recommendations, you said we have many things to do, but I just didn't hear anything that touches those that provide the service. And what are the greatest issues we're seeing today? Our conversation at the legislature has been, how do we fix this collapsing network? And funding is one. You mentioned a little, funding is it, but every time I dig deep into it, I see that our federal policies, and you mentioned the favorite buzzwords about person-centered care. The more we pile on policies, they seem to be having a negative impact on the ability for those providers under a strained environment to provide care. What unique processes or procedures do you think we're going to have to enact to try and recover this network, to stop the damage from occurring today, and then to recover and provide actual person-centered great care versus the path we're on today? So I'd love to understand what are you guys thinking, and what are you thinking out of the box, and how the heck can we help get this process moving forward?
Thank you, Senator Curran. Ms. McGurran.
Madam Chair, Senator Curran. So the adult protection system that I'm discussing today is really a system that's based on informal care and people that are not receiving services from our licensed providers. Those issues that you describe, the workforce issues, the service issues for our licensed providers are very significant, and you'll be hearing more today from the Minnesota Department of Health. I know the Department of Human Services is also very involved in addressing those issues. but it's outside of what I was prepared to discuss this morning.
Madam Chair, quick follow-up.
Senator Kern.
Ms. McGurran, you know, when we look back at many of the things that we're pained with is a whole bunch of federal regulations that what recommendations have you fed up to your counterparts at the at CMS or at the highest level within your agency to try and get those policies modified or actually give us the tools to be able to manage the actual care that we have? We get our hands tied all the time, and we have to stop it. We can hardly, frankly, I don't want the federal government to help us because all they do is further tie our hands. But what conversations are occurring? That's what we want to hear. So whatever's new and creative, because we can no longer live under this oppressive environment. So I appreciate your comments.
Thank you, Senator Kern. Ms. McCurran, did you want to respond or no?
I can respond for adult protection, Madam Chair.
Sure, go ahead.
Madam Chair, Senator Kern, for adult protective services, there are no federal requirements for adult protection. There are federal guidelines, and the first federal funding under the current coronavirus and the American Rescue Plan Act that are coming down, we are working with our county partners to identify the services and supports that they need to have improved outcomes for vulnerable adults. And so those funds that we're receiving are going to be used flexibly to promote outcomes for adult protective services clients who are the vulnerable adults in the community.
Thank you so
Nicole,
much.
did you have something you wanted to add?
Madam Chair, Nicole Stockart with the Department of Human Services. I thought maybe I would just kind of supplement, and Senator Kern, thank you for your questions. I thought maybe I would just kind of supplement what I believe my colleague was trying to describe, that, as you know, DHS is a rather large agency. And so the area that we represent really only covers adult protection services, which again is part of the Vulnerable Adult Act that covers people not receiving licensed services. So I think what I could definitely be happy to do is go back to the licensing division of our agency and perhaps come back with a presentation that is more aligned with what you're looking for regarding service providers and changes in regulations regarding the providers actually providing the services.
Thank you, Ms. Stockart. That sounds good. Members, we will continue with the next two presentations. I still have some questions for DHS myself, but I'll just wait until our presentations are over. Thank you so much, Ms. Stockart and Ms. McGurran. And next up, we have Lisa Timian from the Minnesota Department of Health.
Hi, Madam Chair. I'm actually going to turn it over to Diane Rydrick, but I'll be presenting from my screen.
Okay, go ahead, Ms. Rydrick.
Thank you, Madam Chair, and members of the committee, and thank you for having us here this morning. It's been a little while since I've been able to be in your committee, but we've really appreciated your focus. You've really had a laser focus on, oh, Lisa, is this the wrong presentation? What I'm seeing looks like something for a different hearing. Thank you.
It is. I have too many items that I'm trying to juggle this morning. My apologies.
Good thing we saw it at the beginning. I don't think you would have wanted me to give that presentation. So again, thank you, Madam Chair, and we've really appreciated the focus that you personally and your committee have had on making sure that our elders and that our most vulnerable Minnesotans are safe and are receiving high quality care, not just during the pandemic, which has been so difficult for everybody, but long before that, and we know continuing after it as well. So we appreciate the chance to come here and provide you with an update on our work. And Lisa, could you advance to the next slide? And we can, it's at the core of our mission, but I won't spend too much time on it there. So we were told that you wanted to hear an update on elder abuse and on some of the work that's been happening over the last couple of years within HRD. So we will walk through our work during COVID and what we've seen in terms of complaints and findings, and I think that'll complement what you just heard from DHS. We also heard that you wanted an update on assisted living licensure, and so we will have someone here to speak to that and give you an update on that. And we'll talk about some of the continued improvements that we're making in our work within HRD and MDH, and some of the overarching issues, which I know you are very aware of within long-term care, that I think are important to acknowledge. They're really kind of an elephant in the room when we talk about regulation and we talk about the impact of COVID. We can't do that without talking about staffing issues and wage challenges and burnout and other things that are happening in the industry. That's really just an important contextual factor for talking about how we move forward from here. So Lisa, if you could go to the next slide. And we do have a lot of slides, but I will try and move pretty quickly through them so that there is time for questions. Just really, really briefly, we looked back at the slide deck from the last time we were here in your committee, and it was back in the very early spring of 2020, or last time we were here to present on HRD's work. It was in the early spring of 2020, and it was really not that long after we had had a lot of attention on the work of OHFC, the Office of Health Facilities complaints, concerns about backlogs, concerns about our accountability and our responsibility to provide the right oversight for that work and for the people who are really governed by that office. And we had a transition of the commissioner around that time related to those serious challenges that we had within that part of the department. We had an OLA report that walked through some of the issues and recommended improvements that we needed to make. And at the same time, we were working together with stakeholders from providers, consumer organizations, many legislators and policymakers on trying to figure out how to stand up assisted living licensure in Minnesota as, I believe, the last state to not have a system like that. And there were a number of work groups that were convened at that time in 2018 and into 2019 that led to the assisted living licensure language passing with bipartisan support in 2019. And we'll speak more about that later, but I think it's just important to look at where we were before we talk about where we are now. Next slide. And we will talk again more about assisted living licensure. I just want to highlight these key accomplishments of the last couple of years before we move into some of the details. And Lindsey Krieger, who's going to be joining you in a moment, will talk in more detail about assisted living licensure. But because I know that she will be very Minnesota modest about her team's accomplishments, I really just want to call it out. This was the largest new licensure program that we have established within MDH in many years. It was a phenomenal lift during a pandemic. It launched on time, it launched smoothly, and it launched with, after having had countless stakeholder conversations, training sessions, TA, webinars, Q&As, FAQs, videos, everything we could possibly do to help this be a smooth process for providers and to help consumers really know about what this would mean for them and what additional protections it would provide for them. And it is something that we are incredibly proud of, that it went as smoothly as it did. There were a lot of concerns all around about whether we'd be able to get it done during the heart of the pandemic, and we did. And we feel good about it, and we don't usually toot our horn that way, but I think it's important to do. We've also been moving forward on organizational transformation within the Health Regulation Division, in part sparked by some of the challenges that we had a few years ago related to OHFC, but really just recognizing that it's a complex division. There are around 300 people who work in that division, and they regulate a very wide swath of providers and professions, all of which are really unique. And there are state requirements, state regulations, there are federal requirements. They interact with each other, but they're different from each other. And we really saw that there were silos in how we did our work and challenges around the organizational structure and ways that we could really transform that division in order to work more effectively and more consistently across the different areas that we regulate. That's been a challenging process. It has meant people's jobs changed. It's meant their reporting relationships change. It's meant that the way that work gets done changes and the way people relate to each other change. And anyone who has led organizational change efforts knows that that is a multi-year process. And it is well underway now within the division. The other thing I just want to call out is strengthen stakeholder relationships. We've been meeting weekly throughout the pandemic with the long-term care imperative to talk about issues, concerns, to bring forward concerns that have come from individual providers or members of their organizations. We share guidance with them as we're developing it so that they have a chance to weigh in. We meet regularly with the Ombudsman's office, with consumer advocates. It's been kind of a trial by fire, I think, over the last couple of years to do this work. And relationships between, regulatory agencies and the providers they regulate are not always smooth, and they, will never be completely smooth. We come from different perspectives and we won't always agree. But I think we would all agree that we have come out of these last 2 years with better communication structures, better and stronger relationships, and a better ability to just call each other up and talk about problems that are happening and to work together on solutions. And that's something that we're feeling good about. So with that preamble, I'll talk really briefly about COVID and long-term care. I know that you've seen this, so we won't spend much time. COVID took a heavy toll in our long-term care facilities. This is the COVID cases in skilled nursing and assisted living facilities over the course of the pandemic. You can see how extremely high the waves were back in the end of 2020, and then now at the end of 2021 and into the Delta and Omicron waves. And then next slide is deaths in assisted living and long-term care residents. I think what's really important to note here is what happened after vaccination became available in long-term care. Although we still saw a wave, we still saw an increase in deaths during the Delta wave and then Omicron. It was far lower as a percentage of deaths than what we saw in Minnesota overall. And that is due in large part, not only to the stronger protections that providers have been able to put in place and what they've learned over the course of the pandemic, but because we have such high vaccination rates in long-term care. We are one of the top states in terms of vaccination rates for residents in skilled nursing facilities in particular, and for staff. And we have one of the highest booster rates for residents and staff in long-term care of any state in the nation. And that is because of no small effort on the part of MDH and providers and our partners in the community, which again, I think is something that we can feel good about. Next slide. We have had supports for long-term care throughout COVID. You all probably remember when the long-term care battle plan was announced back in early May of 2020, and that set up a five-pronged process or five-pronged structure for supporting long-term care, including crisis staffing support, support for testing, and support for vaccination, also PPE and supplies. That team remains in place and will remain in place, even though the demands on it right now are fairly low as we've come out of the Omicron wave. But we have been providing those supports to long-term care providers for the last 2 years to countless numbers of nursing homes and assisted living facilities. We also still have a COVID case manager function within the department, which means that if a facility has a COVID outbreak, they have somebody who has infection control experience and just experience understanding how long-term care facilities work and what the regulations are. And they can advise them and consult with them about how to do their testing, how to work on vaccination, how to handle quarantine and isolation, et cetera. We also still have the ICAR team, the infection control support and consultation that we provide to long-term care, both individual facilities, but also to long-term care as a whole. And all of these folks with epi and infection control expertise communicate very regularly, not just with individual facilities, but we've had weekly, now bi-weekly webinars for long-term care throughout the pandemic, so we can share evolving guidance and just offer advice and consultation to them about what they should be doing to keep their residents safe. As you know, we also have had the Minnesota National Guard working in skilled nursing facilities, providing crisis staffing support. The last National Guard team just left the last skilled nursing facility yesterday. So over the course of the last few months, since around Thanksgiving, National Guard teams have supported about 50 nursing homes with 2 or 3 week missions of teams of National Guard CNAs or TNAs. And the response that we have gotten back from the nursing homes that they've been in has been phenomenal. The Guards' commitment and their ability to provide caring support to these residents at a time when they're tired too and they're stretched too. It has been fantastic, and we know how appreciative the facilities have been of that work. We've also supported skilled nursing facilities through the establishment of alternate care sites or hospital decompression sites around the state, which are starting to wind down. Next slide. So just, I think this probably comes out in the last couple of slides that I've gone through, but the COVID response really impacted HRD significantly. At the peak of the response in terms of number of FTEs who have been working on it, I think more than 70% of the whole department had some kind of a response role in testing or vaccination or data or communications. And for HRD, it was in that neighborhood. Around 80% of HRD staff were reassigned at some percentage of their time for some period of time to support the response. And many of them were doing the work that I just talked about, supporting long-term care in various ways. And that was important because it allowed them to bring their expertise as surveyors, as regulators, people who understand infection control, to kind of pivot and provide those supports during COVID. But it has taken a toll on their kind of typical operations during the pandemic as well. Another big change for us during 2020 and 2021 is the direction that we have gotten from CMS. CMS has directed all state survey agencies to prioritize and focus their work differently and more narrowly during the pandemic. So for our federal work with nursing homes and with hospitals, we have been directed by CMS to only be investigating complaints that are at the highest triage level, like immediate jeopardy complaints, and to do focused infection control surveys for the facilities that we regulate. So that has really kind of sharpened the focus on a narrower set of events. But as you'll see too, that means that the number of complaints that have come in, they don't stop just because CMS says to focus in one place. So that means that some things have to be deferred for later, and they don't go away, right? And the state survey work has used a similar prioritization process to really focus on the most serious complaints. And you'll see some data about that in just a moment. The other big change, I think, for HRD during COVID is there have been so many changes in federal guidance for long-term care related to testing of staff or of residents, vaccination, use of PPE, visitation, how to work with contractors and consultants. The federal guidance has changed regularly as our understanding of the pandemic has changed and as community levels of COVID have changed. And that means that there's been a really high need to be kind of constantly monitoring what's coming out of CMS, what are we hearing from CDC, and thinking about how we translate that for the providers on the ground so that they understand what they need to do, both to follow those regulations and not be in violation of them, but to just really understand what it means for them in terms of keeping their residents safe. So that has required a lot of focus on technical assistance and education and consultation and answering questions with providers to help them understand what that ever-changing guidance means for them. And we also have had waivers during COVID, both under the public health emergency and now under some temporary emergency authority under Chapter 12A-08. And that has given us the ability to waive certain requirements for some license types, and we'll provide a little data on that in just a moment, but that's just kind of another whole area of work that evolved that is specific to COVID and has been kind of time limited. So I believe with that, I'm going to turn it over to Maria King. Maria King is the acting division director for HRD, and she's going to talk a little bit about those waivers and about what we're seeing in terms of federal complaints.
Thank you, Ms. Rydrick. Ms. King, welcome to the committee. Go ahead.
Good morning, Madam Chair and members of the committee. My name is Maria King, and I am currently serving as the interim division director for the Health Regulation Division within the Department of Health. And just very briefly, these are the areas here on the slide on the screen that there were waivers implemented for during the course of the pandemic for a variety of sections within our division. Health occupations, home care, hospitals, mortuary science, nursing homes, other specific to maltreatment of the Office of Health Facility Complaints, and supplemental nursing service agencies. Next slide, please. In January of this year, there were some waiver flexibilities reinstated for temporary and emergency provider relief to address hospital and nursing home moratorium bed waivers and nursing home layaway bed waivers. Over the course of prior to fall, we had 142 applications for modifications in beds and in service. And there were 32 approvals for service changes and 110 additional approvals for bed additions. And since fall, we have now had an additional 27 applications, 22 of those coming from hospitals and 5 from other settings, including intermediate care facilities for individuals with intellectual disorders, psychiatric residential treatment facilities, and nursing homes. Next slide, please. This slide here gives an indication of the complaints and facility reported reports that were received between January 1st and December 31st of each of the years that are identified below. And you can see how those came in from the various sources on this graphic here. Next slide, please. On the federal side of things, there have been, I wanted to focus this slide on the most egregious allegations that were coming in for federal providers, and we reference those as immediate jeopardy allegations. And in state fiscal year 2019, you'll see here that there were 794 allegations that came in that were triaged as an IJ, and 323 of those were resulted in a substantiated finding. And that does not mean that they got an IJ, but that means that it was determined that they were substantiated. In state fiscal year 2020, there were 1,438 allegations triaged for federal facilities as IJ. And in state fiscal year 2020, there were 2,913 triaged. And you'll see the numbers of substantiated in 2020. It was 517 of those triaged at an IJ level resulted in substantiated findings, and in 2020, 734. Next slide, please. Wanted to give the committee here an idea of the findings that are being identified across the last 3 state fiscal years. And so there's I'll just review those with you, and if you'll take a look across the 3 years, you'll notice many of them are the same over the years. The most highly frequently cited citation is the first bullet, and then we did the top 5 for each of these years. So common themes are infection control, freedom from accident hazards, quality of care indications and findings, and failures to report allegations of abuse and neglect and/or failures to investigate those. Next slide, please. So here I'd like to turn it over to my colleague, Lindsey Krieger, to go through some of the state maltreatment findings. Thank you.
Thanks, Ms. King. Ms. Krieger, go ahead.
Thank you, Madam Chair, members of the committee. For the record, my name is Lindsey Krieger, and I am a Regional Operations Executive Manager in the Health Regulation Division. While Maria provided you federal data, I also wanted to provide data on state maltreatment findings. This graph gives a 3-year comparison on data in regards to the substantiated findings where we did have an allegation where we found with 51% preponderance of evidence that the allegation did occur for abuse, financial exploitation, neglect, and compliance. As you can see, these numbers are similar across the past 3 years. Next slide, please. Now, in regards to top deficiencies for home care and assisted living, which I'll give an update on assisted living in just a minute, I wanted to highlight what we are finding in providers currently in this fiscal year. I'm not going to go into depth in regards to the areas of statute, but for reference, you can see on your screen the top areas that MDH is issuing licensing orders to home care providers, including the service plan content, TB infection control, individual abuse prevention plans, etc. Now, in comparison, on the right-hand side of your screen, we have assisted living licensure, which is now in place as of August 1st of last year, which brings a new aspect and approach to providers now licensed with this license. As you can see, number 1 is infection control, similar to what Maria discussed in the federal nursing home. New areas of statutes for providers now must meet the Minnesota Food Code. Physical plant and emergency preparedness is also included on this list. Now you'll see resident grievances and reporting maltreatment being cited for failure of providers to have posted their grievance procedure, how to contact the Ombudsman's office, and how to report maltreatment. And I know that we'll hear from Cheryl Hennen in just a few minutes on the Ombudsman's office. I want to talk a little bit more about assisted living licensure and this licensing change here in Minnesota that implemented 7 months ago. So we can go ahead and go to the next slide, please. So assisted living licensure is in Minnesota Statute Chapter 144G. This will help provide an update on how this licensure has worked to improve care and services of vulnerable adults in these settings. Now, as you can see on your screen, prior to or in the 1980s, there were no assisted living establishments here in Minnesota. And prior to August 1st of last year, we had about 2,500 housing with services, 1,663 home care providers, which provided care and services to approximately 60,000 clients, which is over double of the residents in nursing homes. There were 3 main statutes, what made up most people what they knew as quote-unquote assisted living. On the top, you will see 144D, which is housing with services. That was a registration. If somebody was interested in becoming housing with services, they would register with the department, but really didn't have any teeth behind it as far as regulations for that housing aspect. The green circle is 144A, home care. A home care provider is somebody who is regularly engaged with at least one home care service, such as assistive tasks with an unlicensed personnel, services by a registered nurse, or medication management, just to name a few. These areas are provided in the client's home, which could be a home in the community, or their apartment or room within housing with services registration, which sunset or was repealed as of August 1st with the new assisted living licensure. This license is still active, but is different than assisted living licensure. And then prior to August 1st, we had assisted living in 144G. However, at that time, the term was a designation. It was something that housing with services would denote on their registration, and to be the assisted living or have that title, you would need to meet the requirements in 144G at that time and could only advertise as an assisted living with this designation. You can go to the next slide, please, Lisa. So what this new transition of licensure looks like is a little bit of an equation. We have assisted living licensure combined with the comprehensive home care services under one contract to equal assisted living licensure, which implemented on August 1st of 2021. The licensure, what it does is it helps to clarify on who's responsible for what. There is no longer 2 contracts, one for housing, one for services. It is combined with one entity responsible for both. Assisted living licensure also allows residents to age in place. Residents may only contract for housing and then over time add services to their contract as they need them. As mentioned, housing with services is repealed. Home care in 144A is still present for care and services provided to residents in a private setting. Also, assisted living licensure residents are able to contract for services with home care providers above what their assisted living facility may provide if they wish to do so. This is one of the new rights that the residents currently have in place with this new licensure. We can go to the next slide, please. And I want to pause
Ms.
here,
Krieger?
and as Diane mentioned, yeah.
I hate to interrupt you right now. I think there's like 30 slides, right? 36 slides. We just like 3 more minutes if you could wrap this up a little quick. Thanks.
Oh, sure.
Thanks.
Yeah, okay, yep. So as far as licensing and rulemaking timeline, just wanted to just walk through a little bit with what we have as far as the licensure. We have the adoption in 2019. The Department of Health held 17 teleconferences calls, in addition to many conference presentations to help providers better understand the regulations and really help to partner together. We know that this was implemented at a time of the pandemic. How could we provide additional education and information for them to be successful for the benefit of the residents? Now on the right-hand side, we have the rulemaking timeline. Just as a reference for you for time frame, it was something that was an expedited process. It was started in 2019 and moved through the process, really wrapping up. The notice of rule adoption was published on July 19th, 2021, leading into assisted living licensure. Next slide, please. The assisted living licensure rules cover 18 areas. I'm not going to go into them. We did have a lot of engaged public comments and stakeholder feedback. I do want to mention the Office of Administrative Hearing. Chief Judge Jenny Starr did commend and applaud the department and stakeholders for carefully crafting rules. So as we went on it, developing rules on an expedited time frame, we did work to carefully craft them per what the statute laid out for the department and really paying attention to and making sure the rules followed. Next slide, please. As far as data goes for assisted living licensure, the next few slides I have as far as breakdown of providers here in Minnesota. We have roughly 65% of assisted living providers in the 7-county metro area and around 35% outstate. Next slide, please, Lisa. As far as data by capacity, you can see this is a breakdown as the size of facilities for the metro area. There's a large amount of small providers here in the metro area. And if we go to the next slide, Lisa, you can see comparison on the outstate is that there is a smaller number of small providers, but larger number of larger providers in the outstate area. Next slide, please. So when we look at total capacity, which is not the number of total residents, but what the providers have paid for as far as with their license for the capacity to provide services to, we have about 43% of capacity outstate, 75% of capacity in the 7-county metro area.
Ms. Krieger?
Yeah.
We've got the slides now. We didn't get these till late last night, so members didn't get a chance to look at them, but we have emailed them out to all of our members, and we'll take a look at the rest of them. And if we have any questions for you, we will come back to you. I just want to make sure we get to our other presentations. So thank you so much, Ms. Krieger, and MDH. We'll have some questions here at the end. Next up here in person is Ms. Cheryl Hennen, the State Ombudsman for Long-Term Care. Thank you, Ms. Hennen, for being here in person today. Thank you.
Thank you, Chair Housley. Good morning. I want to thank also Senator Curran and the Committee on Aging and Long-Term Care Policy for requesting that I testify today. I am Cheryl Hennen, the State Long-Term Care Ombudsman. I have been with the office since 2004, and it is my privilege to serve as the State Long-Term Care Ombudsman. So, next slide. I'm not seeing my slides. So slide 1, slide 2. The Office of Ombudsman for Long-Term Care. Could we go to the next slide, please? There, thank you. The Office of Ombudsman for Long-Term Care is an independent program of the Minnesota Board on Aging, which means we are independent from any other state agency that provides services. Our office's mission is to empower, educate, and advocate alongside Minnesotans who receive long-term care services and supports to ensure that their rights are upheld. And here is where I have a very strong connection among many with each one of you members because we work daily with your constituents. Our vision is that everyone receives long-term care services and supports to enjoy a high quality of life and a high quality of care. You've heard the term today, person-centered. We take that term very seriously. What does that mean? It means that we focus on the person and support them in making their choices and having control over their daily life. People are not defined by a diagnosis. So last week, I announced to my staff that I will be testifying before you today. So one of my staff, on their own, took it upon themselves to send me a note asking that I read this to you today. Quote, "As you know, our staff are in the field every day, supporting residents of long-term care. What I am hearing from staff is that the situation for long-term care residents, as well as facility staff, is almost the worst, if not the worst, they have ever seen. And there are limited options to access providers outside of facilities as well." So this would include people who receive home care in their homes. COVID-19 was and continues to be devastating for long-term care residents. And now residents are coping with a deepening staffing crisis, compromises in care, and facilities and community providers with an uncertain and tenuous future. The appropriation to the Ombudsman's office came just in time. Without it, we do not know how we would have gotten through the past 2 years. But my staff are weary, I'm included. They are deeply passionate about their work and the people they serve, but it is difficult for them to see every day what our clients are facing. Our clients look to us and to the legislature for solutions to address the staffing crisis, ensure their rights, choices, and safety are protected, and guarantee that they continue to access their loved ones and remain connected to their community. Now more than ever, people receiving long-term care services need us to hear their voices and to respond, end of quote. And that is what you are doing, and I appreciate that. Slide 3. This is one before that. I will not read this bullet for bullet because I am here today to really focus on the reality, so you get to hear about what's happening out there. This slide lays out for you what the federal law mandates that the Ombudsman services are to be. And today you will hear in large part from me about the investigations. Next slide. I want you to see a visual. Most of you committee members were here when the appropriation was approved. So before that, you would have noted testimony I gave. There were very few numbers on these maps. And now we have 25 total. We were working with about 12 or 13 prior. So I wanted you to see this visually. Every number represents a staff member within your area. Next slide, please. I want to express here to all the staff in long-term care facilities and staff providing in-home care, I want people to hear my gratitude and appreciation for all the care, compassion, and courage that you have provided over the last 2 years. You have made a difference in countless lives every day. Here on this slide, you see here I want to provide you with what Regional Ombudsman working through the pandemic has been like. In 2020, I made a very difficult decision to move all staff out of being in the field, and they have been, or at the time, March 2020, through early about fall of 2020, Regional Ombudsmen and volunteers were providing virtual visits. Our office conducted 615 in-person visits once we were out again, which started to happen January of 2021. I want you to know that a complaint investigation is when a resident expresses dissatisfaction or concern to the ombudsman. There's a lot more around that, but with ombudsman investigations, they include observations, interviews, and also the record reviews. In addition, we also met with 312 resident and family councils. We conducted over 1,007 non-complaint related visits, and with non-complaint related visits, we are meeting our obligation of in-person presence. In-person presence is so incredibly important because that's how you develop relationships and trust, not only with residents, but also with staff. Next slide, please. So our office tracks serious complaints of elder abuse. Our definition of elder abuse is broad. It encompasses physical abuse, psychological abuse, sexual abuse, gross neglect, and financial exploitation. This data that you see on the screen is a snapshot of what is going on in long-term care facilities. It does not tell the whole story. On the slide is a graph of elder abuse complaints by calendar year 2020 and 2021. As you can see, an increase in sexual abuse complaints from 9 to 19. There were modest increases in gross neglect and financial exploitation, followed by psychological abuse. Physical abuse complaints declined by 15%, but it is important to note that these statistics may underestimate the actual abuse statistics because we were not able to be in person. We advocate for quality of care that ranges from basic needs such as nutritious food to serious issues of abuse. We work with law enforcement, CMS, Center for Medicare and Medicaid, the state licensing agency, the Attorney General's office, Elder Justice Center. I want you to understand it's a wide breadth of people that we work with in order to conduct our work. Put simply, we are the eyes and ears in facilities. Fear of retaliation is prevalent. When you rely on someone to assist you in the bathroom and you complain about how staff treated you, how will you be treated the next time you need help? Will you be left longer and forced to go to the bathroom on yourself? These are actual questions that one resident told his ombudsman keep him from reporting some problems. We work to empower the resident, especially in abuse circumstances. I would like you to understand what confidentiality means in the ombudsman world. It's our core principle of resident individual rights, and the ombudsman program requirements are explicitly laid out in the Older Americans Act to preserve the fundamental trust relationship between the resident and the ombudsman that enables people to feel safe reaching out to us. No resident identifying information is released without the consent of the resident or court order. For this reason, we are not mandated reporters. And there's a good reason for that. With a resident's permission, we can and do report abuse, as most often we may be the first the resident will report it to. The federal law also does allow us exemptions to be able to report without the consent, and that will happen largely when someone does not have capacity and they do not have a representative or a legal guardian. So I want you to understand we would not turn a blind eye. When we are made aware of abuse, our office will encourage resident and family members, staff, and others to file a complaint. You've heard from people who are in charge of the MARC system, as well as the Office of Health Facility Complaints. We also may do reporting. We have seen a decrease in complaints on accident and falls. Excuse me. Slide 7. Move to slide 7. Next, I'm sorry. Here, failure to report, failure to receive care. Our office, I want you to see how our office tracks complaints involving failure to receive proper care, including poor quality care planning and delivery. Here is where we see a decrease in complaints on accidents and falls and physical restraints. However, an increase in complaints for the use of chemical restraints, such as using medication to subdue a I want to share with you a few examples of casework that we have been involved with that exemplify the problem of staffing, which also can lead to abuse. So you are seeing a picture. The gentleman who lives in this nursing home gave us consent to share this photo with this legislative hearing. He knew I was testifying today, and to share a situation. He is 58 years old. He is impaired. He has an amputated leg. This photo was taken September 2nd of 2022. The resident said the caption in the photo should be, "Desperate times call for desperate measures." He states that he needs help transferring, but staff do not come in a timely manner, so if he wants to be continent, he often must transfer himself unsafely. Staff put up a call before you fall sign, which you see in the photo. But when he calls, he can wait for up to 3 hours. Sometimes he sits on the toilet so long, awaiting a response to his call light, that he starts banging on the walls or grab bars for help. He says there simply are no staff. He reports that everything was better when the National Guard came in, but when they left, things fell apart. He installed, if you see, there's a bullhorn on this picture. He installed the bullhorn in the bathroom for times when he is waiting on the toilet longer than 30 minutes. 1 week, there was no clean laundry. During one episode of incontinence when staff did not arrive, he had an accident and wipes were not restocked, so he had to use a bed sheet to clean himself up, and he is at high risk for falls when he transfers himself without staff assistance. Recently, his transfer sling was not maintained and checked by staff, and it broke while he was suspended midair, and he fell to the floor. His regional office person from my office has been involved since November of 2021. Different resident, reported staff don't come when the call button is pushed. The regional ombudsman asked her, what would she do if there was an emergency because she doesn't have a phone? She said her plan would be to open her window and call for help into the street. And my final example is a 70-year-old man residing in a nursing home for a short rehab stay after undergoing surgery. Short staffing for this man meant that he went 1 month without a bath or shower. He complained of smelling himself, itching, no thorough cleanup after incontinence, and his family was concerned that he would get sores. He had a surgical incision that was not monitored and medications that were late or missing. He asked for baths and medication adjustments, but they were not addressed until the regional ombudsman was involved. So when you ask for solutions, you've got them in this office. But we also, and I know this committee, I thank this committee, is taking these staffing problems very seriously, and we all need to work together for those solutions. Next slide, please. So here's our data on non-case topics. So what does that mean? That means that we did not open a complaint investigation. And when you talk about prevention, this committee has called out on how do we get ahead of this and prevent. So this is one way that I believe we are your ounce of prevention, because if we are involved early on, we are able to mitigate, resolve, hopefully, the situations going on. I wanted you to see the topics that we are discussing with residents, facility staff, family members, and we've been able to resolve. They didn't turn into cases. This slide shows topics of the discussions that we've been engaged in about abuse, call lights, falls, bed sores, and restraints in 2021 and 2020. So advice and consultation from our office may resolve the issue without conducting and turning it into a much larger problem, which ultimately is much better for the resident. Next slide, please. I wanted to show you the top complaints, which my guess is none of this surprises you. And we are seeing things improve, which is good, but there are still areas that need improvement. So I wanted you to see the top 10 complaints. So every year I must submit a report to the federal government, so that's why this is the federal fiscal year time span. And no surprise to any of us, visitation, top issue. We know, as the health department even pointed out, there were many regulations issued that were there to mitigate risk. So visitation, people felt that they were in lockdown status. And as you know, there were many things that were stopped: communal dining, group activities. Residents many times would report, even directly to me, I feel like I'm in prison. In fact, one Vietnam veteran said, this is what it felt like being a prisoner of war. The second most frequent complaint, no surprise to you, staffing. The third most frequent was residents being deprived of rights, such as personal liberty or freedom of choice, right of assembly. That's what the category reads from the federal government. Oftentimes for regional ombudsmen, this will be instances where a facility is preventing cohabitation, does not recognize their right to refuse care or treatment, and other civil rights issues. The fourth most frequent is residents are reporting they're treated with rudeness, indifference, or insensitivity. And then the fifth is about discharges. And over the period of time of COVID, which would have been March 2020, 2021, you know that there were people being moved for good reason, safety reasons, but we also saw a lot of other involuntary discharges happening. So as the fifth most frequent complaint around discharge, we worked with many people receiving involuntary discharge notices. And also this includes when residents were transferred to the hospital without a bed hold, that would be from a nursing home, and then not allowed to come back. Next slide, please. So here, I want you to get a sense of the activities that we are to report and track so that you are able to note what else we have been up to. And in addition, this is in addition to the complaint work. So when you look at information and consultation to individuals, as I was referencing earlier, that's almost 9,000, as well as, and there, I give you a number of 13,560 activities logged in cases. So that has to do, again, with working with people on advising and empowering them. We have many activities to facility, to staff. We are to be involved in the survey process. When the health department goes out, they are to seek our input into the survey. And we take very seriously our work with resident family councils. So, last slide. I mean this. Thank you, members of the Senate Aging and Long-Term Care Committee, for the opportunity to present. As I look back, please accept our gratitude for the steadfast support, especially over the last few years. Your support is linked to the improvement of resident quality of life and quality of care statewide through our office. And I'm also very proud to say and want you to know that at a national level, we are noted to be doing some very, very good work. Thank you.
Thank you, Ms. Hennen, and thank you for what you do. It has been a rough couple of years for you and your staff over there. Speaking of, I just have two quick questions for you. Do you have enough staff?
Madam Chair, committee members, we are closely monitoring that because, as you may know, assisted living licensure expanded our scope of authority. So as we move forward, I so appreciate that question. You may see me back asking for more.
Thank you. I was wondering, that was one of my questions. The other one is, when we passed the electronic monitoring a couple years ago, how is that going? Are you getting more complaints or complaints about the monitoring or the cameras in the room? Is there anything that we need to change?
Madam Chair, committee members, we anticipated that question, so thank you so much for asking. So people have the right to put an electronic monitoring device in their room or in their apartment. Wonderful law. Many states contacted me to say, could we see what Minnesota did? The law also includes, if a person fears retaliation, well, I should back up. A resident must inform the facility when they're going to place the device. If they fear retaliation, they may take advantage of a 14-day exemption period to place the camera without notifying the facility, but they notify our office. Our office has received few notifications and consent forms for electronic monitoring under that 14-day exemption. The 14-day exemption, as I mentioned earlier, we we'll see that coming from people who fear retaliation, or they may have already filed a police report. What we wonder, as I talk to my staff about this, because we have a person that's very dedicated to monitoring and working on this, and we may come forward at some time to review that law. But it does appear as though, as time has went on, providers are more accepting. They're much more amenable to the fact that they are there. And since we had a period of time that we were not in, I'm not sure how much that played into it, but the fact that we've been receiving very few 14-day exemption notices may be a good thing.
Thank you, Ms. Hennen. Members, any questions for Ms. Hennen, DHS or MDH? Senator Eakin.
Thank you, Madam Chair and members. And Ms. Hennen, thank you so much for the important work you're doing and for drawing attention to the problems that long-term care is experiencing now with the staffing crisis, the staffing shortage, the difficulty in attracting the quality staff that we need in this critically important profession. I'm concerned, especially about the future, because I know the demands are only increasing on long-term care as the baby boom generation now are entering years when they need those services. You've pointed out some of the problems we're currently experiencing, I think, are going to become even more pronounced as we move forward. And not just in Minnesota, but across the country because of the aging demographics. And I'm curious about how we do compare with other states. I mean, we have serious problems here, and I'm wondering if we're right about where the rest of the country is in terms of the number of, abuse or neglect cases, or as far as staffing issues, if we're better or worse. I'm thinking if we're better, that doesn't speak well for what's happening in the rest of the country, if it's even worse yet. But I know it's hard to make those comparisons, obviously, because I suppose there's different standards of measurement, and maybe some states do a better job of looking into these things, as your office has done a great job. But wondering if there's any sense of where we're at, when compared with the other states in the country.
Ms. Hennen.
Madam Chair, Senator Eakin, very good question. What other states have looked to Minnesota for how, in the ombudsman world, we were not so-called sanctioned from going into facilities. Many states struggled with ombudsmen not even being allowed in facilities. We were noted for very little trouble in that area. In terms of staffing, I feel, as I serve and represent Minnesota at a national level, Minnesota may have been somewhat delayed in getting help in the early stages, although, and what I mean is trying to figure out how do we maintain these staff without seeing facilities closing. And so we seem to fare sort of right in the middle, if you will. Minnesota is not looked at really struggling. The one thing that Minnesota is noted for is the work that came out of this office in terms of addressing sexual abuse. And if this committee would ever want to see what we've done in terms of developing a curriculum, I'm more than happy to come back. I will say that we are somewhat struggling with how to do better at maintaining people's homes and making sure that people's rights are upheld when it comes to not arbitrarily transferring or not providing any source at all. So the staffing crisis, what we share with many states is what salary, what benefit packages, how do we lift the actual status of people providing the care. So in summary, I believe that our state is looked at, it could be because I am asked many times to provide presentations at the national level, that we're doing pretty well, but we are struggling along with many other states in terms of staffing, in terms of use of antipsychotics. We are much more concerned about the increase in use of chemicals in order to reduce or minimize the care that may be needed. So when I think about what are the topics right now where Minnesota is joining a number of other states, it is in staffing and it is in making sure that people have also access to visitors during a pandemic. While we did have essential caregiver guidance in place, we saw so much devastation in terms of isolation, what isolation does. So Minnesota didn't quite fare as well in the beginning, but what we, again, thank you committee, because once we got out there as staff, we worked very hard to change that. While loved ones, essential caregivers are not to supplant staff, they are extremely important. So I really think we need to look at, which many states were wondering, what is Minnesota doing? Making sure that there is law in place that guarantees the next pandemic, we will not be blocking people out or away from their loved ones during especially a pandemic.
Thank you, Ms. Hennen. Senator Putnam and then Senator Coran.
Thank you, Madam Chair, and thank you to everyone who testified today. We heard some, I think, heartbreaking information at certain points. But what is doubly heartbreaking is that there are undoubtedly a number of stories that we weren't able to hear and that no one's heard yet. So thank you, everyone, for being here today to share your stories and the information that we've heard. I do have a sort of two-part question, which I assume is for our friends at MDH. And that's, I'm curious about the categorization of these events, of these concerns that are reported to MDH. And then two sort of questions about that. The first would be, if someone were to pay for services in a facility and the facility failed to provide those services, does that count as financial fraud or a concern, or is it physical, or is it neglect? Kind of where would we put an event like that were it to occur? And secondly, I'm really interested in the question of immediate jeopardy. What exactly is that? Where does the definition come from? What kind of guidelines do we have for how we deal with it? I mean, when I hear the story of our friend sitting on a toilet for 3 hours, that sounds an awful lot like something that might be cast as jeopardy to me. But I'm guessing it doesn't quite fit the definition. So could I get a little bit of information on both of those two questions, if you wouldn't mind, please?
MDH, I don't know who wants to answer that. Lindsey, Ms. Krieger.
Madam Chair, Senator, in regards to the question on allegations and coding allegations, it really depends on what the allegation is that comes in. If it's failure to provide care or services, that may be a neglect allegation. If it's in regards to abuse, emotional abuse, verbal abuse, physical abuse, that would be categorized as abuse. Financial exploitation is in regards to funding, money, stealing goods or stealing money. Also categorized in financial exploitation is drug diversion. So the medication, the residents' medications are their own medications. And so if there's a staff member or if they're stealing of medications, that would be categorized under financial exploitation. If I'll answer your question. And then I'm going to turn it over to Maria, Ms. King, to help with the immediate jeopardy question.
Maria, Ms. King?
Yeah, thank you, and thank you, Madam Chair and Senator. We, for immediate jeopardy, there is a federal, it's a federal verbiage, and there is a federal definition of it, and it's a situation in which a provider's non-compliance with one or more requirement of participation has caused or is likely to cause serious injury, harm, impairment, or death to a resident. And the type of example that Ms. Hennen was sharing would certainly be something that we would look into at our office, and it would get triaged at a high level. Thank you.
Thank you. Senator Putnam, follow-up? You're good? Senator Coran.
Thank you, Madam Chair, and thank you, Ms. Hennen, for all the work you do, and you know where I stand on most of it. But you talked about the top 10, you know, kind of the top 10 complaints and falls, and where falls was one of them. And so when you look at those things, I know because I've looked through them and the crazy policies we have about you can't have bed rails on there because that's considered a restraint of some sort. So we lower the bed and hope they fall shorter distances onto a pad that we lay onto the floor. In your work around those types of areas, are policies, you know, and this is more generally, but are policies leading to some of these accidents and falls? Because I know in nursing homes, I go in them, I visit them myself, and you see the pads on the floor. So are people tripping over the pads, or are they falling and landing on the pads? Or are there other things like we saw the gentleman that the story you shared, where nobody showed up and they have to act on their own because of the neglect of failure for staff to report? Do you see policies getting in the way of many of these complaints that you have that drive the very complaints?
Ms. Hennen?
Madam Chair, Senator Coran, I believe you raise a very important issue because policies, and it may be also a good question someday more to explore with the regulators, because they may not be easily understood, they may not be current, they may not be, especially during COVID, we saw such a flurry of guidance changing rapidly. Some may be outdated. And are they keeping up with where we are right now with providing care and where people choose to have care? So I feel it's a very valid question. How are the policies in place actually keeping people safe and doing the right thing?
Thank you. Madam Chair, just to follow up.
Senator Coran.
So I appreciate that, Ms. Hennen. So what we didn't have in your presentation is, because you literally are, you're the voice of the citizen, because we've made this so complicated, and so sadly, they can't get the work done of the agencies that should be doing the work, so you have to come in and provide them with guidance through the process. But I think you're the only one on the street that's doing the real work that is really touching the families. And so what I think we'd like to see, or I'd like to see as a committee, is on a continued basis, is recommendations. You see the cause and the actions and the complaints, and what is it from your perspective that we'll be looking at from a policy? Because everywhere we turn in this body, I know every legislator is extremely frustrated because we turn to some crazy federal policy, and what I don't see is pushback, because we don't even understand the impact to those who deliver the services. not only the value of the dollar that we degrade through the life cycle of the consumption of government before it touches the very entity who provides the service, but the policies are equally detrimental, and nobody's talking about it. And what I want to see is us unite around what are we going to do as an agency. I'd love to find it something to work with the Attorney General on, to go back at our federal government. They're causing harm, great harm, not only in the ability to staff, but harm, physical harm in the process around this perfect world of the person-centered care plan. That sounds good, but the reality is it's causing harm. And then just to comment, Madam Chair, is that we're all here because of everybody in this room. We helped create the problem. Over the last 40 years, we've divested billions of dollars of health from dollars to that very end-of-life health care, nursing homes, because everybody's now managing their assets differently, right? We didn't strip any government dollars out of this care network. We stripped all private dollars which were there to take care of your end-of-life care, right? Your most 2 expensive years of your life. Protect your assets, create a trust to protect them. So now mostly everybody's on the government dime. So if we're going to do that, then we have to make sure that those families start to take care of their families in their homes, and we need to preserve this network for those that have done everything that they possibly can do, and those that don't have families. And that's what I'm concerned, that we're on a path that it's very tenuous as we move forward. So, Ms. Hennen, we'd love, in the future dates I know we're running out of time, but to really look at what is that list of recommendations? Where should we go after? Because I just don't hear that, anybody talking about it. And so we make ourselves feel good a lot. I want to make sure that the people we serve feel great. So thank you.
Madam Chair, may I comment?
Yes, Ms. Hennen, go ahead.
Thank you, Madam Chair. Senator Curran, I like your comment on pushback, and I'll address the recommendations. Be on the watch. I will be submitting to you our annual report. Within that annual report, we'll list problems and recommendations. And pushback, weekly, we are meeting with the state agencies and addressing where we need to see change in policies, procedures, and regulations. You don't get to see it all in action, but are we pushing back? We push back in a respectful way, and we've made progress. So if ever you want to know, well, tell us what that looks like, Ms. Hennen. Please invite me back.
Thank you, Ms. Hennen. We will invite you back, and we might have MDH back and DHS also. I had a whole bunch of questions that I wanted to ask, but we are out of time. So what I'm going to do is I'm going to email them to everybody on the committee and to MDH and DHS, and we can kind of have a little thread going there and maybe bring everybody back. So thank you for coming in person. Thank you, everybody, for being on Zoom today. And with that, we are adjourned.